Hello, everyone. I'm Lynn Cremando for YogaUOnline, and I'm here with Dr. Ginger Garner. Dr. Garner is a doctor of physical therapy who's board certified in lifestyle medicine. She's also a retired athletic trainer. She has postdoctoral training in functional and integrative medicine, which includes yoga and Pilates, visceral mobilization, dry needling, and rehabilitative ultrasound imaging. She's spent 26 years teaching integrative and lifestyle medicine internationally, and she's spoken at over 30 conferences worldwide. She's the author of multiple book chapters and two medical textbooks, which, if I'm not mistaken, Ginger, at least one of them is a bestseller, Medical Therapeutic Yoga and Integrative Lifestyle Medicine in Physical Therapy. And from those, she's developed certifications for PTs and OTs to work in the field of therapeutic yoga and lifestyle medicine. She's based in Greensboro, North Carolina, where she owns and operates Garner Pelvic Health and Living Well Institute. She has a podcast, the Living Well Podcast. If that's not enough, she's raising three sons. As a grandmother of a boy, I hat off. She's been active in community service and holds leadership roles in American Physical Therapy Association for the American Physical Association. And additionally, she's a mentor and thought leader in areas like voice to pelvic floor connection, rehab ultrasound imaging, and trauma-informed practice. So I'm pleased, Ginger, that you could take time from your insane schedule to
Thank you.
spend
Thank
time
you,
with
Lynn.
us today.
Oh, I appreciate it. Yeah, thank you for the invitation and thanks for carving out the time to chat. I appreciate it.
Now, in addition to everything, your practice has kind of evolved into one where you're helping women take the journey between the phases of their lives from puberty onward, or should we say, maybe a little bit later.
It has become increasingly important with the passage of time. And just to kind of jump right into the conversation, it wasn't until I think late last year that the Menopause Society published an article that is kind of a clarification. If we wanted to use more intense language, we might say an expose, a review on the Women's Health Initiative back from the early 2000s, around 2001, 2002, when that was published, that immediately said, oh, hormones are bad and no one should be on them. Women shouldn't be on them.
I remember.
And basically the two cents, from that article, what was most important that stuck with me was that a generation, quote, an entire generation of women was deprived of therapeutic intervention, which leads to catastrophic incomes and early outcomes and early mortality. And going through that progression and ushering women through, prenatal through pregnancy, and seeing already back in 2017, I spoke at the World Congress on Physiotherapy in South Africa on the global maternal mortality crisis and how we had no standards of care for physical therapy in the United States. So kind of the crisis in women's health is across the lifespan, and it still exists. We still have higher first day infant death rates and maternal mortality rates than any other developed nation in the world. So we have that problem, but we also have this massive problem where women are going to spend the majority of their adult life and that is perimenopause to menopause. And so as a physical therapist privileged to work in a field, if I might clarify, to work in yoga, to work in mindful movement, to work in integrative medicine, and realize there is so much that we can do to change the trajectory, which also includes, since I have a clinical doctorate and I'm able to practice, in the medical field, it allows me to bridge that gap of being able to screen women and say, okay, according to what I see, whether it's levels of progesterone or estrogen are in such a way that it's creating worse orthopedic, musculoskeletal, and pelvic health, if you will, and that we need to work to get hormone replacement therapy, for example, or HRT. So it puts me in a privileged position to be able to go between those worlds and say, okay, integrative medicine would work here, but okay, in this case, we're going to need HRT, we're going to need other supplementation and changes, and then we pull in the medical management side.
Glad you brought that up, because when I was thinking about talking to you today, and I started thinking about the societal lens of menopause, it's all about loss, degradation, desirability, lost youth, no sexual vitality. It's all about, you know, your usefulness as a sexual desire creature has gone away. And there's just such a negative piece to that. And there's this word that came into my mind, which was crone, which is now used as like to describe a witch-like person, or someone who's unpleasant and all of that. And if you go back, this phase of life from perimenopause onward, but particularly after menopause, was seen as wise, and the place where you really come into power. So I want to talk about that, but in the context of talking about that, I wonder if you would dispel your favorite menopause myths, if you have a couple.
Oh, I have a lot. I have a lot. It should be, and busting menopause myths. Honestly, I just came like rushing in from clinical practice to sit down and have this conversation. And so it's very relevant to me. Just this morning, I'm having conversations about what isn't true. And there are so many things about perimenopause and menopause that just flat aren't true. As I was researching something, I was reading the literature recently. I wanted to see what popular media, and when I mean popular media, I don't mean like People Magazine and, like Washington Post or something. I'm talking about medical websites that are supposed to be peer reviewed and vetted, right? And giving you accurate information. So think about the highest level of information that you could glean from Google, and you start to think Ivy League and, different medical websites, right? And I just took a peek at the information on some of those websites, and it's like my mouth was hanging open. I was like, there was such a level of misinformation out there. And one of them had something directly to do with what I see every day, which is pelvic floor dysfunction and problems. And it actually said on this very prominent website that shows up at the very top of Google, and Google prides itself on its algorithm and vetting and accurate information. And at the very top, it said that pelvic floor muscles go through a relaxation phase in menopause. And I was like, no.
Unless it's the opposite.
Right. I'm like, I'm not sure what they're even talking about there. And then it went on to, so again, if you've heard your pelvic floor is just going to be weak or you're going to leak or whatever, that's a no, 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 no. None of that has to happen. And then it went on to talk about, here's another one that's a favorite to bust, is the hot flashes, night sweats, that kind of thing. The vascular symptoms that, women tend to suffer from that have a pinpoint connection in the brain that we don't fully understand, but it comes down to thermoregulation. Like our body kind of loses the ability to regulate that. Does it lose it or does it shift? So the article, again, from another top tier site that had been vetted, said, here's how you treat it. Drink ice water, dress in layers, think cooling thoughts.
The fan.
Okay. And I wanted to throw something at my computer. While these are distraction techniques, they aren't actually treatment. And a lot of these symptoms can be easily resolved, and you can get to the root of the problem with the issue through integrative medicine, through functional medicine approach, through lifestyle changes in medicine, through pelvic, physical therapy that I love to, and what I've done for the last, as long as I haven't had my license, which is going on 27 years, I think next year, is to integrate yoga into it. And so those are some of the big myths, because weight gain, loss of libido, hot flashes you just can't, that you can't change, pelvic floor muscle relaxation and leakage. None of that is like inevitable, and all of it can be prevented. And there's too much information out there that just says it's just menopause, and it's not true.
Mm-hmm. The other one I mentioned briefly, but I think you have a lot to say about it, is that menopause starts when you're like 45. The perimenopause, look for that around mid to late 40s, and then menopause is 50. But that's not really true, isn't it more of a continuum?
It is very much a continuum, Lynn. Yeah, it is. If you look at the statistics, plus or minus a few years, you can expect to be in the window. So if you were born, let's see, in 1978, okay, so if you're listening to this and you are 1978 and earlier, congratulations. You're pretty much in perimenopause to menopause age range. So you can be as young as 35 plus or minus a few years and already be, experiencing signs of perimenopause. And the sad thing about that is a lot of women, and I was just reading a statistic on this today, I believe it was from Menopause Society, that the majority of women don't even know what the symptoms of perimenopause are. And that's why a lot of them end up in my office, because they're jumping around to practitioners. If your practitioner is not menopause literate, what happens? You get bad information. You get told that, oh, you just have tendinitis, you just have plantar fasciitis. Oh, you have pain with, attempted intercourse, painful sex, have a glass of wine and relax, which makes my right eye twitch. When they're not recognizing that even if a mom is postpartum, and here's the big thing, postpartum and perimenopause can look the same.
Wow.
And so you can be postpartum and 22 years old or 27 years old and still have signs of perimenopause, because it is a time of estrogen deprivation. You have less estrogen in your system postpartum. And the longer, let's say, you're nursing as a new mom, you're going to look more like you're perimenopausal. And sometimes even moms at that age and women at that age are going to need some kind of hormone therapy.
So it's true that hormone therapy has been so controversial, and to the point where I think there are women who probably would really benefit who would say, oh, no, I'm going to get cancer.
Mm-hmm.
Um,
And that's a huge myth to break also, that if women are diabetic or have heart disease or a history of cancer, that they can't be on it. And that's not true. All of that came out of the Women's Health Initiative study, which was deeply flawed and has now been clarified. And you can look up the paper from, I believe it's late 2023, from the Menopause Society.
So what is the truth? Is hormone therapy, first of all kinds of therapies have undergone evolution as well. I'm assuming hormone therapy has become more nuanced and less generic. Is it
Yeah, yeah, absolutely. And I think there's a lot of fear mongering in general, probably based on that original study.
Mhm.
That again, thankfully has now been clarified. But that means, gosh, okay, that was 22 years ago. So that's 22 years of missed therapy and good health outcomes and even early mortality, because the biggest reason women are admitted to nursing homes is incontinence.
Really?
Mm-hmm. And if you're not treating menopause appropriately, a woman is likely to be incontinent. So that is really disturbing. It's something that can be prevented, and that means a woman could be living with vitality into her 80s and 90s instead of losing all of her quality of life and even being at higher risk for dementia. So yes, hormone therapy and natural forms of replacement because some women don't tolerate it. And some women do have particular risk factors that would make it contraindicated, which is a case by case basis, obviously. But by and large, most women are going to be tolerant of it and would be able to take estrogen, progesterone, et cetera, in some format. And it's, the clinical guidelines are very specific in terms of what that looks like.
Yeah. So we're talking a lot about kind of the medical piece here, but you've got another hat. You've got the integrative medicine and the yoga and the therapeutic experiential hat. So can you go put that hat on for a moment?
Yeah.
Uh,
So when we, I look at, I look at menopause through, again, I find it a place of privilege to be able to look at it through the medical management lens, through Menopause Society, through looking at and reading and vetting the literature, and then also looking at the literature on the integrative side as well, and being able to put that hat on. So I feel like our medical management side is it, I don't know if limited is the right word, but there's only so much that can be done on the medical management side. It's a lot and it's important. And it comes down typically to hormone replacement therapy or some version of that if they don't tolerate it. But on our integrative side, on the therapeutic side, you've got a universe of things available to you that allow you to intervene through the lifespan from perimenopause on, that in some ways can be even more powerful than the medical management offers. And so that's what I get excited about. It's why when women talk about menopause, they often don't even consider that a pelvic physical therapist could even talk about or manage menopause. And that's another myth to bust, to say, hey, actually, we have a great number of tools, and maybe even more tools than the medical management side has, to be able to intervene.
yeah. Now, from a yoga perspective, I'm imagining that because part of the image of, my childbearing years are ending and this phase of my life is ending and I am uncertain, is kind of acceptance and wrapping your whole body and brain around change and things like that. How do you, and I think of that as being the kind of the piece that yoga can really bring into play, other than the physical practices. But how do you approach those kind of psycho-emotional,
Mm-hmm.
I mean,
Yeah.
even if you never wanted children and your childbearing years are ending, that's a piece of your life that is coming to an end. And that awareness can start in perimenopause, of course. But how do you approach that psycho-emotional piece?
Well, gosh, I can speak to that professionally and personally. Um, I will say that women who have been through a surgical menopause have the most harsh, kind of hammer drop experience, because menopause is worse. It is like a train wreck, you know?
Sudden, right?
Yes, it is sudden. It is unrelenting. It is unforgiving. It is like overnight you experience just flood, instead of it being gradual, trip down the river, it's like getting dropped into like class 5 rapids and going, okay, deal with that. And no one prepares you for it. And that's what I had to experience. I had to experience a surgical menopause where, unfortunately, in spite of nearly 30 years of experience, no one prepared me for that.
Wow.
And the medical management side they dropped the ball, because it was before the paper came out, way before the paper came out, that debunked all the myths. And so I was existing in a time of forced menopause, that everybody was still afraid of hormone replacement therapy. It was like this awful, like apocalyptic purgatory where you're like, what the heck just happened?
Yeah. I guess
And
probably especially because some condition triggered the need for a surgical.
right, for a surgical intervention. And that's where I also try to guide women through being able to discern from their side, because I have to be very upfront and honest about our current healthcare system in the United States. And it actually applies outside the United States. I have people traveling from the UK, from Canada, to see me for management. And I've taught in other countries. And so I begin to really understand and appreciate strengths and weaknesses in other healthcare systems. And you have to pull back and look at the 40,000-foot view and go, okay, what is our healthcare system aligned with? It's currently aligned for, in large by and large, profit. And when you look at a profit mechanism machine, you have to then question, does this individual have my best well-being and health in mind? Or are they actually upcharging me to get paid more for this visit? And so I want to be able to empower patients to come in and go, do I really need that surgery that's being suggested, or that aggressive drug that's being suggested? Or can we handle this in a more natural, holistic, cheaper, in fact, integrative way? And if they can go out and be a more informed healthcare consumer, I feel like I've done my job,
Uh,
because I want them to recognize that the perimenopause symptoms that start and can start early and can start during postpartum. So if you are a postpartum mom, maybe whether you're a young mom, older mom, it does not matter. You're going to have the same symptoms that can reflect looking like being in perimenopause, that even if you're postpartum, you can get help for that. You don't just have to suffer through all the symptoms. And so some of them are these: anxiety, brain fog, depression, fatigue. Fatigue can be massive, migraines and headaches, which you don't normally think of, um, cardiovascular issues like heartbeat racing, kind of fluttering heartbeat, hot flashes, night sweats, incontinence, irritability, joint pain, low libido, painful sex, period changes, urinary tract infections that just come out of nowhere, sleep issues, weight gain, and skin and hair changes. That's not all of them. There are over 30 symptoms. Some people say even more. So if I can teach women how to recognize those symptoms and
mhm.
then let them know, hey, we can change these. It doesn't matter if you're actually in perimenopause or postpartum, your body doesn't know the difference and will still respond in the same way.
As you said, and you were reading that list, I can think of a lot of conditions for which those symptoms would be attributed. Is there a test for perimenopause?
That is like the holy grail. It is, because if we had that, it could certainly be easier to intervene. But there really isn't, unless a woman is going through a surgical menopause, and then you can measure and see
Yeah,
things
for
just
sure.
absolutely plummet. And that's where you know immediately that that may be needed, right? That replacement may be needed, or supplementation. But if someone's going through a natural menopause that's not surgical, then it becomes much harder to actually measure anything with labs. And labs, by and large, in medical management, and what the position statement from, Menopause Society, for example, is that, labs are not going to be indicated in that situation, particularly talking about blood serum labs. And the reason is, your hormones fluctuate throughout the day, throughout the month. And if you are still cycling, you're only getting a tiny little grain of sand on the seashore snapshot of what your estrogen is doing at that moment of that day, of that month, of that year. And that becomes not very helpful. Over time, there is, and this is emerging evidence, is that salivators, saliva, so a salivary test or a urine-based test would then give you more information about how your body is actually metabolizing those hormones. And so then you've just taken a deeper dive under the surface. And that's why you'll hear so many, practitioners who may or may not be menopause literate say, oh no, we don't do labs. We just treat your symptoms. And in part, it's kind of true. But then there's another part of that that isn't true. You do need to measure labs sometimes.
So it sounds like educating ourselves about what could be happening and taking charge, which, going back to the psycho-emotional, taking charge and driving the car
Yeah.
for that phase of our lives by ourselves, and finding a medical practice or team to work with as a partnership is going to be pretty vital.
Yeah, it's absolutely essential. If we look at the something like the menopause rating scale. And there was a study that was done a few years ago, like 2018, 2019. And it looked at scoring what a cutoff score should be for treatment of symptoms. And they realized that the cutoff score that they had created was too high. They needed to actually lower the cutoff score because the highest level of agreement was on symptomology that was ruining kind of quality of life. Like, I can't live like this, that women were saying things like depressive mood, irritability, anxiety, musculoskeletal symptoms, muscle and joint discomfort. And that's a huge one because that's the wheelhouse where I live, musculoskeletal health all the time, particularly pelvic health. So that, bladder problems and fatigue were like 81% and up were extremely bothersome, and women wanted treatment for it. So that they tweaked the rating scale so that if they lowered it, their scoring would be in agreement with what they felt like women would need to be treated for. So those symptoms that I just read are symptoms that are treated in a menopause literate pelvic PT office, for example, and should be treated on a regular basis and should not be ignored at all. But too many women are again told, oh, just accept it. It's because you're fill in the blank age, or it's because you're postpartum, right?
Also, you're a hormonal woman.
Right. We can't measure hormones. That doesn't
Hormonal.
matter.
It's how women are.
Right. It's the default mode. It's the status quo. It's whatever. It's biology. And that's just total bunk. It's not true.
So as a first step in self-empowerment and education, you are going to be teaching a course for us on some of these myths and empowering your journey through midlife and beyond. So talk a little bit about the course, because I think, given everything you've said, this would be useful for women of any age, even post-menopausal women.
It is. It doesn't matter. Your age does not matter at all. You could even be experiencing some of these symptoms if you are on drugs that are called aromatase inhibitors. What are those? They are inhibitors that can be found in many different things. Even women who are going through cancer treatment will be put on these drugs. They are essentially, estrogen suppressors. What happens when you suppress estrogen? Well, one of the big things when I mention musculoskeletal issues, which, that's why I use yoga so much to treat it. One of the massive things with estrogen suppression for anyone, postpartum, cancer, perimenopause, menopause, postmenopause, is that estrogen is an inflammatory mediator. And as soon as we take it away, there goes the inflammation. Yeah. So when you talk about your risk for type 2 diabetes, your risk for neurodegenerative diseases, dementia, no one wants at their end of their life to be that burden on their family or to pass from a disease like that. It's awful. And yet most of the women in my family have passed that way. And they were also estrogen deprived. They also had surgical menopause forced on them when maybe they didn't need that. Because if we don't have to look far back in time where a hysterectomy was the cure for all kinds of things.
For everything.
Yeah. And by and large, it is incorrectly still used that way. For like example, with women with endometriosis, if they go into someone who's not endometriosis literate, that surgeon will say, oh, a hysterectomy will help. No, that's not the cure.
Also, right? And we might as well take your ovaries while we're in there. You're not using them.
Oh, goodness, yes. And if you are facing a hysterectomy and it's actually surgically necessary, you have to, at all cost, if possible, preserve the ovaries, because they are going to produce estrogen even after menopause has happened. You're going to be able to take what your body has and optimize use of it. So if we can, in a natural way, in a holistic way, in an integrative way, maximize what the body is doing with whatever estrogen level it has, or it's being replaced, then we can maximize, or rather, maybe I'll use this word, minimize the inflammation that's going to occur that causes all kinds of things.
Yeah. So we're going back to the course. These are some of the issues you're going to delve into and helping people to kind of decipher what they need to educate themselves on. And hopefully also how to find a good healthcare practitioner that is qualified.
Yeah. Yeah. We tend to use the phrase
That way, that's
menopause.
qualified, not just has a
Yeah,
sense, but that is actually qualified to speak to you about these things.
correct. And if I could like send a huge message home, it would be that, the take home message would be that just because someone has their degree on the wall and they're a degreed doctor of any type does not equate to any menopause literacy at all. Um, Even GYNs. And I have so many colleagues and friends who are GYNs who will tell me and told me straight up, um, we got absolutely nothing on menopause. Or it was like a voluntary lecture they could attend, but they got nothing on management. And if you look at polls of GYNs, and I say I'm separating OB and GYN because there's uh, conversations, in the industry about what would that look like if it was OB or GYN instead of lumping fertility into gynecological care, because we aren't just vehicles for fertility.
Yeah.
So if I could, press that message, I would say yes, just because someone has a doctor, of whatever hanging on their wall does not mean they absolutely know how to handle, anything when it comes to menopause. If you look at some of the other stats on it, like decline in estrogen leads to um, difficulty with mitochondrial production, which means, hello, building muscle mass, having energy, decreased levels of antioxidants. Okay, great. Now my cancer risk just went up because I have less estrogen.
My frailty,
And
my
yes,
frailty
and
risk, my
frailty.
osteoporosis risk, all of these
Mhm.
risks that are associated with aging just went
And
up.
impaired insulin. A study just came out. I'll be talking about this in the course because the studies prior to this, I was so excited to see this come out. All the studies prior to this were against hormone replacement for insulin regulation. And a new study just came out that is much like debunking the, Women's Health Initiative, the negative things that came out of that study that said, no, actually, it's protective. And when you have a decline in estrogen levels, you have impaired insulin regulation. Both of my, and family members, I have two family members that passed, and diabetes was a huge complicating factor. So was dementia, so was osteoporosis. All things that came as a result of direct estrogen deprivation and an unnecessary hysterectomy.
Well, and they're also calling diabetes dementia type 3 diabetes now. They're calling Alzheimer's type 3 diabetes. So you are connecting some really important dots there.
Yeah. Yeah. The
So,
literature is very moving. Yeah.
yeah, we could go on, clearly, but we'll save some for the course. Thank you so much for
You're
taking time
welcome.
out. And it's been fascinating. I'm sure the course is going to be really useful. So thank you for today and looking forward to the course.
Thank you so much. I'm looking forward to packing a lot in and talking about, not just the research and what it says, but actually elemental practical things that you can, put into practice. And of course, finding practitioners around you and also giving you a yoga practice that you can get started on now,
Yeah.
because it's all about prevention. Prevention is worth a pound of cure, right?
Well, thank you again, and we'll see you in class.
Thank you.
Bye.